Let's hear a word from this episode's advertiser. Chemotherapy can damage bone marrow, specifically hematopoietic stem and progenitor cells, the source of all blood cell lineages. Learn more about the myelosuppressive effects of chemo and an FDA-approved therapy at www.chemomyelosuppression.com. You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. And today we are joined by ONS member Moe Schwartz, PharmD, Professor of Pharmacy Practice in the James L. Winkle College of Pharmacy at the University of Cincinnati in Ohio, and member of the Cincinnati Tri-State ONS Chapter, to answer the top pharmacy questions from oncology nurses. The advertising messages in this episode are paid for by G1 Therapeutics, Incorporated. Thanks for joining me today, Mo.
Thanks for asking me. I'm looking forward to it.
Yeah, I think that a lot of oncology nurses have questions about, we're always asking about new drugs and new treatments for our patients and things like that. But it's always something that we like to have that pharmacy colleague to be able to bounce questions off. So as we were planning for this episode, we asked our listeners to send in questions they've always wanted to ask a pharmacist. And believe me, we received plenty of responses. And I'm excited to get started and ask you as many as we can.
Okay.
So let's start with the basics. Package inserts. How do we read them? What information is crucial? And what should an oncology nurse look for?
So I would never have thought I would say that package inserts are so important when I first started in practice. They were difficult to get to. You had to get out, vial of the drug and get out the package insert, try to read that small print. Now we have them readily available online. And I use Daily Med, which is from the U.S. National Library of Medicine. Daily Med, if you just type in Daily Med, you can get the most current package insert, which makes it really helpful to get the information. Where I go to it, and I go to it a lot, I look at current indications because those change so much. I look at dosing and I look at dosing modifications. So there is clear indications of when you should do modifications of dosing, especially with some of these new oral medications. It tells you what size the tablets come in. So I don't work in a specialty pharmacy where I dispense these. I don't see these. So that gives me that information. It gives me warnings. That helps me figure out what I'm going to monitor, what things I'm going to look at when I look at patients. It gives me information about the kinetics so I can look and see if I'm going to be concerned about, say, renal dysfunction or liver dysfunction. The other thing, it talks about use in pregnancy and risk in pregnancy and lactation. And that's something I think we miss a little too often because some of these patients are on these for a long time and, they may consider like pregnancy. And so it's good to have that information. So I would say this is a really valuable resource that you could use to get those quick answers that have been well established in clinical trials.
Those are really great points. And I agree with you. It's so much easier now to be able to, find them and really look specifically for the information that we need to get right away with our patients. So thank you for that. So next, we've had several drug shortages in recent years, and some affect treatment, premeds, and other things. So our listeners have been discussing changing premedications to oral rather than IV administration. What do nurses need to know about providing premeds orally versus IV?
Yeah, these drug shortages really mean a change in our day-to-day practice. And for those of us that work in institutions, it means a collaboration to try to figure out what that change is going to be. Change from IV to oral in many institutions means that those medications will not be covered by insurance. And so often they're relatively inexpensive. And so sometimes we don't even charge for them. But that's one of the things that may be impacted. In terms of oral versus IV, I work in a head and neck cancer clinic. So sometimes people can't take oral. So to really look to see if when you say oral, do you mean liquid or do you mean pills? And is that going to make a difference? I think what a lot of people think about is timing of dosing. When you give something IV, pretty much it's in the bloodstream as soon as you administer it. When you give something orally, it takes some time. So you might want to do your pre-medications a little bit earlier to make sure that there's adequate time for absorption and for the pre-meds to be on board when you give the medication that requires the pre-meds. The last thing I would say is that some of the drug dosing is different when you're giving it IV and PO. Some are not. So kind of establishing that and not having to do it at the last minute certainly is helpful.
That's super helpful. I think that that's really interesting what you were saying about, the cost even. So now, where we used to maybe give IV Benadryl and now we're going to have them take PO. So we may not give it, but we may ask them to take that ahead of time at home. Is that kind of what you were talking about?
Well, some insurances won't pay for the oral medications in certain facilities. And so that means that it would be charged to the patient versus charged to insurance. In terms of taking medications before they come in, certainly we've seen that happen with antiemetics that are a little bit more costly that are oral. We have them buy them if they have an insurance. They have coverage for oral drugs through their, insurance plans, their payers, so that the cost is covered by wherever it can be covered by.
Okay, thanks. That helps a lot. And I think that's something that, especially as more things move to the outpatient, they've continually been moving over the years to the outpatient setting. But as that happens more frequently, we as the nurses administering these treatments need to really know and understand what that cost is going to be to the patient and what their coverage would be for these types of things. So that's really important. So we've had lots of questions about drug timing. So we're going to pivot to that topic next. Are steroid premeds contraindicated in MABs? For example, with bevacizumab and Folfox, should the dexamethasone be given before Folfox, or is it okay to give it before the bevacizumab?
One of the questions that came up when the monoclonal antibodies first came out, and yes, I am dating myself, is that do they require the immune system to exert their effect? And we know that they do use the immune response. They use antibody-dependent cellular cytotoxicity. They use the immune response to help with their actions. So that was where the whole concept of not using steroids came in, because we didn't want to blunt that response to the monoclonal antibody. Well, since that time, we've seen the success of adding rituximab to our CHOP, which the P is prednisone, and seeing that there was not any problem with that. So I don't think there is a problem with using steroids prior to using monoclonal antibodies, and holding premeds to give after the monoclonal antibodies, I don't think is necessary. Now, that's what I think. You may work in a facility where your team has decided that they don't want to use that risk and may not do it, but that's the thought process I go through. The other thing is that these steroids that we use, dexamethasone, you give that doesn't have like just a short effect. It has an effect over time. So even if you're going to give, when you give them, even if you give it after, the monoclonal antibody is still on board, and giving the steroids after you give it, it's going to be on board at the same time anyhow. So I don't think there's that necessity.
Well, thank you. Next question. So Mesna is designed to decrease the risk of bleeding from the bladder when used with cyclophosphamide or ifosfamide. Standard practice for ifosfamide, for example, is to give the first dose of Mesna with the ifosfamide, the second IV dose 4 hours after the start time, and then oral Mesna at home 8 hours after the start time. However, patient instructions written on the prescription bottle say to take Mesna at hour 6 and not hour 8. Can you talk about what is best practice here?
Sure. Mesna and ifosfamide, let's start with that because that's where the approval initially came. The dosing of Mesna was developed in clinical trials. So actually, if you are say you're using a clinical trial regimen that was developed in a clinical trial a long time ago, you may see different dosing of Mesna used. But the way that it was approved was determined based on whether the Mesna is given IV or with the development of oral Mesna, whether it was given orally. So if you're giving IV, classically, when you give a dose of ifosfamide, you give 20% of that dose equivalent in Mesna at the time that you're giving the ifosfamide at hour 0, and then hour 4, and then again at hour 8. The oral Mesna, when it was made commercially available, the initial dose was actually still going to be given IV, and it's going to be 20% of the ifosfamide dose at hour 0. Then to give the oral Mesna at 40%, so double what you would give the IV at hours 2 and 6. So the reason maybe some people use 8, it may be the regimen they're using, because these regimens are usually for short infusions of ifosfamide. There are different standard dosing that is available in the literature when you're giving continuous infusion of ifosfamide. So here's that complex answer simply. So it depends on if it's oral, it depends on if it's IV, so it depends on the way you're giving the Mesna. It depends on the dose of ifosfamide. It depends on the way that you're administering the ifosfamide, if you're giving it by continuous infusion or if you're giving it by a short infusion. And the next thing it depends on is what regimen you're using. So if a study was done using Mesna a different way than what's classically used, you may be repeating that regimen versus using what the FDA package insert says dosing should be. So that's for ifosfamide. Now, cyclophosphamide, that's even more controversial, or maybe just there's more variation because it's not as standardly used. And it's usually used as the study was done, whether you're using it for hyper-CVAD or another type of regimen. So a key thing with using Mesna is that you look at what the regimen that you're using ifosfamide, and that will help you know how to use the Mesna.
It's no wonder we're getting all of these questions. Things can be so confusing. So next we have some nurses in the outpatient setting administer compatible drugs together at the same time. So the patient does not have to sit in the chair longer. However, other nurses say that only one type of drug should go into a line at once. What is your recommendation when nurses have multiple drugs being administered at the same time?
This is a great question because the concept of making the chair time as short as possible for patient convenience is a goal, without a doubt. But then we have to marry that goal with the goal of making sure that we administer the drugs in a way that they're going to be the most efficacious and safe. And that's where the answer to this is depends on the regimen. So there are certain agents that can be mixed together in the same bag to be run together. So certainly putting those through a line together, there's no problem with that. There are other drugs that you want to separate out because you want to make sure that the impact of one drug that you're giving doesn't negatively impact the next drug that you're giving. So it really is trying to figure out the best way to give that regimen. One of the things that I think has happened in practice in the last 10 years that has really helped this is the development of electronic record order sets so that the team can come together and say, this is how we're going to build this order set because this reflects the practice we think is best practice in our institution. So that takes into account the type of pumps that are used, the type of lines that patients have, the patient population that you see, and therefore gives you a good idea of how to do it so it's done the same way each time and it's done the best way each time.
That's such good advice because I think that, one of the things that we do see that is so positive with the ONS communities is, when nurses are asking questions and asking, especially like I'm not sure how this, is done and, looking for best practices. And I think, as you've mentioned, it's so important to realize that there are probably some foundational things that are best practice, but then there are things like you just mentioned that are organizationally best practices, and how your team and your group at your organization have decided to do that and put those things into practice. And like you said, with, the electronic order sets and how that has really, really helped kind of clarify that for folks. But also, like what I'm trying to say, and like you mentioned, that it's just really important to realize that there can still be differences from institution to institution. They might be different, but they might not be wrong.
One of the things that you said, just hit me, something that happened this morning. I was looking at an order set we don't use very often and that I thought we should change. And so I called downstairs and talked to some people and said, why is it written this way? And one of the answers I got was, this is how it has been done in the past. So one of the things I encourage people is when they learn new information, whether it be from ONS or from colleagues at meetings or, from the literature that they see, to think about, should this be something that we change and do it in a systematic way so that it's not a change of one person's practice, but it's a, kind of a practice change, so that we, that we do keep evolving how we deliver these drugs in a safe and efficacious way. I learn a lot from hearing how other people do things and think, as much as I like to think I know the best, I don't. I will change in a minute if it's going to be something better for a patient.
Well, I agree with that. And I think it's so important for nurses to hear that and hear what you just said about asking the question. I think that's the really, really important part, is that if you have heard or you are here, you've heard that somebody else does it a different way and that they have really good results, or it is a more efficient process, and there is supporting literature or something supporting that, and then they do go back and ask the question of, can you just explain to me why we do it this way? That's a great way for a nurse to take the initiative and say, well, maybe we should look at our process. And is it something that we've done for so long? And maybe it's something that we can improve. So yeah, I think that's a great point and something that is really important to take a look at. So let's now move on to questions about safe handling. So monoclonal antibodies come from the pharmacy with an EquiShield attachment for safe handling, and some do not. Can you tell us why that would be?
So EquiShield, or closed system transfer devices, are something that lots of different practices have started to use routinely. And one of the questions always comes up about, when should they be used? And, the answer tends to be they should be used with hazardous drugs. And so then that leads to the next question: are monoclonal antibodies hazardous drugs? And I think the key thing to think about with this is not the term monoclonal antibody, but the specific drug itself. Because monoclonal antibody, amazingly, when you think about the fact that we have not had them that long, they really encompass a number of different types of strategies. The immune checkpoint inhibitors, pembrolizumab, nivolumab, those are monoclonal antibodies. People don't think that way about them because they think they're immune checkpoint inhibitors. They're both. So one of the key things to think about is the specific agent. Is it something that requires special handling? And so that's the way that I would look at it. Now, some monoclonal antibodies will actually say not to use a closed system transfer device just because of compatibility with the closed system transfer device. The other thing that I think is becoming very exciting is that not only are we talking about monoclonal antibodies alone, we're now talking about monoclonal antibody drug conjugates, or those antibody drug conjugates. And that's where I think we're going to start seeing more issues with encouraging people to use strategies for safe handling, because of the fact that these antibody drug conjugates are conjugated or linked to a chemotherapeutic agent. And so they do require that special handling that we see with other cytotoxic agents. So simple answer again, because I do tend to ramble, is it is dependent upon the specific drug product to how the drug should be handled.
And now, let's hear a word from this episode's advertiser. There's a way to help protect hematopoietic stem and progenitor cells in the bone marrow against the harmful effects of chemotherapy. To learn more about an FDA-approved therapy, visit www.chemomyelosuppression.com. So is there anything else that we should think about with monoclonals?
Well, the thing of it, I really encourage people to look at what the monoclonal antibody is, what the target is, and then look at the specific agent. And so like ONS has some nice guidelines about immune checkpoint inhibitors or immune therapy administration that addresses the monoclonal antibodies in that group of drugs. But when a new drug comes out, I always look at the package insert and the drug information about the product to see if there are special dosage and administration guidelines, especially about safe handling. So I would encourage, as new products come out fast and furious, to take a look at them when they first come out so that you're prepared with how you should be handling the drugs and how you should be handling your own practice when you're working with those drugs.
Okay, that's really good. And again, going back to that drug insert to, look at that kind of thing, because they, like you said, they come out so fast and furious now. There's not time for them to get into the ONS chemotherapy guidelines as that quickly. So we need to know. Another thing that people are asking about, oncology nurses are being transferred and not transferred, but moved from different locations to administer, or non-oncology nurses are getting chemotherapy or different types of drugs. What type of drugs beyond anti-cancer drugs are hazardous, and what do nurses need to know about handling and administering them?
I really love the fact that you use the term anti-cancer drugs, because one of the things that I have become increasingly worried about is the feel that people have that the only concerns we should have with oncology are with cytotoxic or chemotherapeutic agents. And I think the first thing I'm going to say is that we really need to look at the risks of handling those drugs used in cancer that are not classical chemotherapy. We've already talked about monoclonal antibodies, but we could talk about targeted agents as well. So I think that's an important thing. And I love the term anti-cancer drug, because many of these drugs are not your classical chemotherapy, but still have risk that not only should we be aware of, but we should be educating our patients and their caregivers about. But there are other drugs, and some of the ones that people think about a lot are things such as some of the antiviral drugs. And so there are lists that are out there, sometimes embedded into your electronic health record, if you have certain programs embedded into them, that will give you lists from NIOSH, EPA, or ASHP, that will give you those drugs beyond cancer-focused therapies. And the key ones that people usually talk about are antivirals, some hormonal therapies, and some bioengineered medications. And so those are just general classes. So again, it's a new drug that you've never given. I definitely think learning from our background in oncology, worthwhile taking a look to see. And there are resources that you can do that, including the package insert.
I think you're right. And it's so important to educate even, like you said, our non-oncology colleagues, because there are medications that are administered that aren't specific to oncology, but they are hazardous, and how important that is. So these last few questions that I have for you don't really fall into a clear category, but they're still important. So we're going to end today's episode with a rapid fire round.
Okay.
What are some resources for figuring out drug-to-drug interactions?
The first thing I would say is look at your electronic health record and see if there's anything embedded into it that you can tell. Second of all, you can look at your package inserts and get some information. if you're specifically looking at certain types of interactions, such as pharmacokinetics, because I know everyone loves looking at those, there are some resources that are free, such as the Flockhart table. I always think of this because I think of that show, but never mind, we're not going to go there. So you can look at those to see if there are potential for drug interactions. But I think this area is one of the most important in drug therapy in oncology, and that it's worthwhile listening to some lecture on it, to reading about it, because I think not only do we need to look at drug-drug interactions in terms of kinetics, we need to look at them with dynamics, which means I need to know if when I'm adding the drug, is it going to increase fatigue in my patient? When I'm adding drug A to drug B, is it going to increase my QTC interval? So really important to take a look at your resources that I've mentioned and other ones you may have, including the people that work with you, to help you identify this critical aspect of care.
Excellent. Next, ever-evolving treatment modalities and drug updates can be overwhelming. What advice do you have for nurses navigating these changes?
So I think one of the best things you can do is to be familiar with the resources the day before you're going to use a new drug that you don't see. So I like those updates because they give you the generals of new therapies that are evolving, new targets, new strategies, things to think about. But when it comes to nitty gritty, I don't care if I read the original study 5 times. I am going to pull up information about that drug so I know the most important things I need to tell the patient. And one of the things I didn't mention, and I'm ashamed of myself, at the end of package inserts that I've created in the last couple of years, there are patient education materials. I don't use them usually, but it's a great way for me to look at key points to think about if I'm educating a patient on a drug I don't use every day.
That's a really good point about that patient education at the bottom. That is definitely something new and really helpful as these new therapies come out. What are the various roles of an oncology pharmacist?
I love this question because as much as I consider myself an oncology pharmacist, I consider the person that I call today at a community pharmacy to help me get an antiemetic regimen worked out for a patient, at the oncology pharmacist for that patient as well. So an oncology pharmacist may be the person that prepares the medication. It may be the person that reviews the drug order. It may be the person that educates the patient alongside the rest of the team. It may be the person saying to the team, this is something that you didn't consider, I think is important. It may be the person's pharmacist who they go to every day. And with specialty pharmacies, I like to bring them in. So by making sure that all pharmacists are aware of what's going on, that's the way that I think that we can optimize care.
Excellent. How can nurses best collaborate with their pharmacy colleagues on patient education?
So I think most places develop a role, and I think that's great. So my role at University of Cincinnati is different than I had done at Johns Hopkins or when I was at University of Pittsburgh. And that's fine. I like the role I have now. It's a great way for me to interact with patients. But I'll tell you something, I work with some phenomenal colleagues that have experiences I don't have and have ways of looking at things that are different and better than how I think of them. So I think that one person owns education is so wrong for the patient and their caregiver. So I think working together. So if I'm the one that explains it and my colleague Brandy can explain it better, I'm letting her explain it better. If the nurse navigator has a better relationship and all of a sudden that the understanding is better when it comes from her, then I turn that over to her. People are really different. They listen to different people more or less, capitalize on that.
That's a really good point. You know, it is. It's just really important to know who your resources are and how you can work together, because the end goal is always the same: to do what's best for our patients and give them the most information and education they can have. So what's something about oncology pharmacy that is not often discussed, but you wish people knew more about?
I've said that oncology pharmacy, they extend beyond the person that's standing next to you in clinic. And what I really am thinking about is that there's lots of people in clinic or in your practice that have different roles. So what I would really say, I would encourage everyone to value the contribution of all members, not based on their discipline, not based on their experience, not based on the perceived hierarchy of who's in charge, but to listen with an open mind, because that's how we'll learn new things and better optimize patient care. I have a really great opportunity to work with pharmacy students. They come to the clinic, they don't know much about oncology except what they've had in the course, which I hope is really good since I coordinate that. But they come with this, but they have all this knowledge that I don't have. They have value to bring. So instead of thinking that our roles are so defined, open up and listen to everyone, because their value will only help us make better treatment decisions.
I love that. I just love the idea of that, like taking your hat off, your name tag off, your credentials, your position, and sitting down at a table and just talking and listening and being open to what people say and how everybody can best learn. And I just think that's so important for us to do today. But I love that part.
Yeah, I wish I would have done it when I was younger. I don't think I was wise when I was younger, and wanted so much to show my role and wanted to own certain parts of the care. I think that time has taught me I can learn so much from almost anybody in the room.
Yeah, I think that's important for all of us to think about, though, and to realize. So thank you for that realization and sharing it with us. So what resources do you recommend for nurses wanting to learn more about cancer drugs or pharmacy in general? We've talked about a lot of them today, but what would you kind of highlight?
So, different people learn different ways. I think that, and this is not because I'm talking to ONS. The reason I'm a member of ONS is because I really value the contributions that it does to its members, and therefore ultimately patients. So whether it was my niece who's an oncology nurse, or my neighbor, or the people that work with me in clinic, I think that ONS has so many offerings that can meet your needs depending on what your needs are. If it's listening to lectures, great. If it's going to lectures, great. If it's reading the updates that are printed out, great. I do a lot of reading of those things that come across my email now that give me updates. And things I don't work in hematology anymore, but I want to keep up on that. I want to know what's going on. So I read those when they come across my email. I think find the things that you enjoy getting information from and do those. Don't force yourself to do things that you hate.
Yep, that's really valuable too. I think that's so important. You can't have somebody say to you, well, you have to do this is the way you need to do it. You need to know what way you learn best and how you can find those. But knowing where those resources are so valuable. So I have enjoyed once again talking with you today and learning so much from you. I think this is a great way for oncology nurses who are new to oncology or nurses in general to learn more about how we can best work with our colleagues in the pharmacy department. And I can't wait for our next podcast so I can hear about that show you were talking about, number one, but just to continue to learn and work with you on these valuable topics for oncology nurses to improve our patient care. So do you have any final comments for us today?
The only thing I would say, well, first of all, I want to thank you because I really enjoyed talking to you. I mean, of course, I enjoy talking to you as I feel that we're longtime friends and colleagues. But the other thing I wanted to say is that when I think of some of the questions that we were asked, there is no right or wrong answer. And I think that sometimes in practice, you're working in an environment and somebody says, this is how we do it. This is the right way. I think there are a lot of times where, the answers are, there's three things, but we just decide to do it one way. So really, I think questioning, trying to understand the rationale, and if there's not rationale, that's a really good thing to know. So I really appreciate people wanting to learn more of the why of what we do versus just how do we do it.
Great. Well, thank you again, Mo. I appreciate it, and we love having you on our podcast. So thanks.
Thank you. And it was really nice.
Learn more about protecting the bone marrow, the source of all blood cell lineages, from the damaging effects of chemotherapy at www.chemomyelosuppression.com. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.